Good morning, good afternoon, good evening, wherever you are. My name is Julienne Anoko. I am the Risk Communication Community Engagement Focal Person for Emergency Preparedness and Response at the WHO Regional Office for Africa. I would like to welcome you to this webinar on community-based surveillance in ongoing Mpox, Ebola virus disease, and Marburg outbreak. You are many of you who are joining from the 5 continents, and we are very, very happy to have you here. We are going to start our webinar. First of all, we are going to show you the code of conduct. Please, if you can put the slide on the code of conduct, please just read that code of conduct. We will leave it to you for 20 seconds. Please read it. And the main thing I would like to focus on as the moderator of this webinar today is to tell you that all WHO events are guided by the highest ethical and professional standards. And all participants are expected to behave with integrity and respect towards all participants attending or involved in any WHO event. Slide, please. Now, let me take you through the housekeeping remarks. You have interpretation available in French and in English. On the right side of your screen, my screen, you can see the interpretation button here inside this red cycle. So please use Q&A for questions regarding the topic and presentations, and use the chat for questions regarding IT or logistic, and to introduce yourself. You see the chat here inside this red cycle on the left, and on the right, you can see the Q&A button. This session is being recorded, and your attendance is consent to be recorded. All the session materials, including session recordings in English and French, will be emailed to the participants in the days following the webinar. Your feedback is very important to us. A survey will be shared in a follow-up email after the webinar. Slide, please. I would like you just to have a look on this for 20 seconds before we proceed. Thank you. Slide, please. Now, this is the agenda of our session. We have already talked about presented the housekeeping, and I will present the objective just in the following seconds. We will have presentation from DRC, the Democratic Republic of Congo. Nigeria will follow. Burundi. We will have a pool of questions that we need your help to answer to this question. And after that, we will have a community-based surveillance presentation in public health emergency, which is a joint presentation by several partners. At the end, we'll have a Q&A, and we'll close this webinar. So community-based surveillance is a proactive approach that involves local communities in monitoring health-related events. The key objectives are to enhance early detection, engage with communities, collect local data and health indicators to inform public health decisions and policies, empower individuals and communities on health issues and surveillance methods, build the capacity to enhance the skills and knowledge of community members regarding health surveillance, and strengthen local health system and network, ensure sustainability for a long-term health monitoring and response strategies, and finally, community-based surveillance ensures integration of community-based surveillance with health system. By achieving these objectives, community-based surveillance can significantly enhance public health outcomes and resilience against health threats. So please, we will hear the objective of this webinar is to share with you countries' experience on community-based surveillance during outbreaks, the challenges, the gaps, and strategies to overcome those. We will hear from the Democratic Republic of Congo, from Nigeria, Burundi, and a joint experience conducted at the continental level. Please join me to welcome Dr. Benjamin Kalambai, who is the Mpox Operations Manager in the Republic Democratic of Congo. Please, Dr. Kalambani, you have the floor. Colleague, please just share the presentation of Dr. Kalambani here. Thank you. Over to you, Dr. Kalambani.
Ok, merci à tous. Nous avons l'opportunité de vous présenter l'expérience de l'accord de la RDC sur la surveillance à base communautaire dans la lutte contre les épidémies. Cette expérience va se faire sur les avancées que nous avons maintenant, les défis que nous avons rencontrés. Je ne sais pas si vous m'écoutez.
Oui, nous vous écoutons très bien, docteur Kalambani. Vous avez 10 minutes. Merci beaucoup.
Ok, merci beaucoup. Avancez avec le slide. Oui, dans notre expérience, nous avons fait la surveillance passive et active qui se résume par les préparations, les réponses aux épidémies. Ces expériences nous ont conduit à vous montrer l'exemple que nous avons eu avec un programme CP3 soutenu par la Fédération internationale de la Croix-Rouge. Dans ce programme, nous avons travaillé sur les outils qui sont le cahier du volontaire qui a en son sein les différentes définitions communautaires qui aident les volontaires ou les récos à se reconnaître et identifier certains signes au niveau communautaire. Dans ce package, nous avons différents outils que nous avons mis ensemble et qui ont facilité cet accès au niveau de la communauté. Dans ce paquet aussi, la fédération a adapté un module de formation que nous avons appelé approche épique, dans lequel nous avons des informations sur la grecque, la surveillance à base communautaire, les notions sur le soutien psychosocial au niveau communautaire, la protection, genre et l'inclusion dans toutes les actions que nous menons sur le terrain. Ces aspects ont y a touché environ plus de 20 000 volontaires et sur le terrain, nous avons vu l'évolution des notifications, des alertes qui ont augmenté dans toutes les zones dans lesquelles nous avons fonctionné, ce qui a fait qu'il y a eu diminution et détection rapide de toutes les crises et les moyens d'intervention communautaire ont été mis en place pour étouffer dans l'œuf certaines crises qui pouvaient aller de l'avant. Dans cette expérience aussi, nous avons milité dans l'approche One Health. Dans notre collaboration, nous avons trouvé que les secteurs de santé humaine est tellement structurée et développée, et il fallait appuyer les autres domaines comme la santé animale et la santé environnementale, dans lequel nous avons essayé de travailler avec ces différents groupes qui ont capacité nos volontaires pour travailler dans l'alerte. Quand il y a alerte, et ils viennent faire les investigations. C'est pour ça, vous voyez, dans certains contrées, là où nous avons développé ce projet de développement, vous trouvez qu'il y a moins de crises qui ont évolué. Nous citerons un exemple, la crise de choléra au poste frontalier de Loufou, que nous avons pu maîtriser avec la zone de santé dans moins de temps, puisque ça a été annoncé en avance, les moyens ont été mis en place et nous avons étouffé. Quel est encore notre acquis? C'est cette coordination au niveau local. Cette coordination au niveau local, ça commence par l'unité au niveau des aires de santé. Les aires de santé qui communiquent directement avec les communautés et qui remontent toutes les informations au niveau des zones de santé. Et autour de ces aires de santé, il y a les partenaires qui se retrouvent et qui causent régulièrement pour le bien-être de chaque communauté. Goé, quels sont les défis que nous avons actuellement épinglés au niveau de la surveillance à base communautaire? C'est l'insuffisance des agents de santé communautaire. Ce n'est pas seulement une insuffisance, mais un faible engagement communautaire pour la surveillance à base communautaire. Cet faible engagement est dû aux faibles motivations des agents de santé communautaire dans presque toutes les zones de santé et aires de santé. Cette faible motivation entraîne à quoi? À une difficulté dans la remontée des alertes et des investigations. Les alertes peuvent être là, mais les personnes pour aller investiguer ne sont pas aussi motivées. Pourquoi? Puisque nous avons des accessibilités géographiques difficiles. Il y a l'insécurité au niveau des zones d'intervention. Des fois, les zones d'intervention ne sont pas couvertes par l'Internet. Des fois aussi, la logique ne suit pas, la logistique ne suit pas. Nous avons examiné, parmi les défis, nous avons trouvé que l'absence de la digitalisation empêche que nous puissions avoir des informations en temps réel. La faible attention au niveau de la surveillance de base des routines pose problème. La dépendance financière externe pose un problème puisque les financiers peuvent être aussi bloqués. Le suivant. OK. Maintenant, dans ce sens, qu'est-ce que nous pouvons amener pour outiller davantage cette activité? C'est former et outiller les CAC. Les CAC qui sont les cellules d'animation, d'action communautaire, qui regroupent et les recours et les volontaires et tous les acteurs communautaires qui se retrouvent au niveau des recours. Cette formation peut être faite à partir de notre approche des modules communautaires que nous avons fait. Nous allons nous réunir avec les autres si prochainement c'est possible. Et nous pouvons faire cette approche intégrée, ça pourra aider beaucoup plus les pays. Autre idée à renforcer, c'est susciter l'adhésion de la communauté. La surveillance à base communautaire ne peut pas se faire sans l'adhésion communautaire. C'est pour ça notre approche que nous avons pu mettre en place a aidé à l'engagement communautaire, a aidé à remonter les analyses de feedback communautaire régulièrement quand nous avons des questions au niveau de communauté. Nous nous asseyons, nous faisons appel aux experts qui décortiquent, donnent des solutions et nous rentrons au niveau de la communauté pour parler avec eux et trouver ensemble des voies, des solutions ensemble avec la communauté. Nous devons voir comment redynamiser ces cellules d'action communautaire. Des fois, à d'autres endroits, ne sont pas bien activées. Nous devons mobiliser les ressources locales en mettant en œuvre des AGR pour financer ces actions de surveillance à base communautaire qui ne sont pas tellement bien suivies au niveau communautaire. Nous devons encore renforcer le partenariat et la coordination au niveau local avec tous les partenaires et tous les acteurs qui sont impliqués dans ces activités. Le suivant, avec tout ce dont nous venons de parler, nous avons proposé quelques solutions ou opportunités, à savoir de un, faire un plaidoyer pour intégrer les volontaires qui sont les acteurs communautaires de premier rang dans les systèmes nationaux de la surveillance à base communautaire. Nous avons aussi plaidé pour qu'il y ait une plateforme digitale pour la transformation rapide et sécurisée des données venant du niveau communautaire. Et nous plaidons aussi cette opportunité de renforcement de la collaboration locale et stratégique avec les partenaires clés, dont cette collaboration doit commencer au plus bas possible au niveau de l'aire de santé, des fois qui sont très éloignés de leur zone de santé. Merci beaucoup. Je suis arrivé à la fin de cette présentation. Vous trouverez la carte de la République démocratique du Congo avec ses 9 voisins qui font de lui un grand pays à dimension d'un continent. Merci, je reste à votre disposition.
Thank you very much, Dr. Benjamin Kalambanye, for this great presentation. We are going to have maybe allow 3 minutes to answer 2 questions. We have 2 questions in the Q&A. In the Q&A, we have 2 questions to you. One question is, can you please expand on the cause of lack motivation among community health workers? The second question is in French. Concrètement, pouvez-vous donner les éléments du renforcement de la coordination locale et la composition du comité? Un des défis est la faible motivation. Comment avez-vous contourné ce défi pour atteindre les résultats? Quel est le type de motivation que vous avez proposé? L'autre question, c'est quelle est la différence entre les agents de santé communautaire et les relais communautaires? Dr Benjamin Kalambanye, à vous.
Oui,
Merci.
je commence par la dernière. Les relais communautaires n'est pas différent des agents communautaires. Tous sont des agents communautaires. Ici, au pays, il y a une stratégie des cellules d'action communautaire, CAC, qu'on appelle CAC, qui regroupe tous les acteurs communautaire. Donc, tous les acteurs communautaires qui composent une communauté doivent se retrouver pour trouver des solutions à leurs défis. C'est dans le CAC où tout le monde est représenté. Des fois, la Croix-Rouge aussi fait partie, les membres. Maintenant, comment nous avons fait pour contourner? Nous avons dit que nous avons présenté notre stratégie. Nous avons mis une formation d'abord très simplifiée, des actions pertinentes de surveillance à base communautaire qui peut être exécutées par n'importe quel acteur communautaire. Nous avons dans ces packages, nous avons un cahier de volontaires qui reprend les définitions communautaires de chaque maladie sous surveillance. Et régulièrement, nous avons des réunions de collaboration au niveau de l'aire de santé. La plupart des partenaires n'arrivent pas à mettre l'action puisqu'ils restent au niveau de la zone de santé. Vous trouverez que certaines zones de santé sont très loin, même à 70 km de la zone de santé. L'action de l'aire de santé à la zone de santé est trop minime et il n'y a pas une bonne influence. C'est pour ça que nous avons rapproché cette influence. À partir de là, tous les partenaires peuvent se rencontrer au niveau de l'aire de santé et mener des actions autour de l'IT de l'aire de santé. Les difficultés que nous avons trouvées, c'était sur les investigations. Ces investigations, il fallait motiver ces investigations. Ce n'est pas seulement motiver, mais mettre en place soit une moto qui peut aller à 50 km, voir le cas, prélever les échantillons, ramener, ou bien une pirogue qui doit prendre les investigateurs, amener à une distance de 70 km, ramener l'échantillon et voir qu'est-ce qu'ils font, quelles sont les actions de santé publique qu'il faut mener sur le terrain.
Merci beaucoup, Dr. Benjamin Kalambani. Je voudrais vous solliciter pour que vous continuez de répondre aux questions dans la section de questions et réponses, s'il vous plaît. Juste pour une question de temps. Merci beaucoup et félicitations pour ce partage. Merci beaucoup. So please let me invite Dr. Adama Abdul from Nigeria. Dr. Adama Abdul is the project coordinator for Community Health Nigeria Red Cross. Dr. Abdul, you have 10 minutes for your presentation. We will follow with 5 minutes of questions and answers. Thank you. Over to you, Dr. Adama Abdul. Welcome again.
Thank you so much. Good afternoon, good morning, and good evening, everyone. Next slide, please. Okay, thank you so much. We want to talk about how we use the community-based surveillance in tackling the Mpox situations, especially in 2 states where the Norwegian Red Cross, through the National Society, are working. The states in other places is the subnational in Borno State and Benue State. We use what we call the NIS platform in reporting our disease surveillance. The initial thing we did was just to train our volunteers how to recognize signs and symptoms of epidemic-prone diseases, and so that there will be a focal person in their communities for them to respond to and also report health risk. And after the training, we also will ask the volunteers to report by using their mobile phone. Volunteers to report by sending short SMS code using the health risk, and which they are also coded, and they will also train during the step-down training. So the NIS platform that we are using will give replies to the volunteers by providing them with health promotion messages, so they can initiate the appropriate first aid responses based on the information they have given, the alerts they have given, the information, the health risk they have informed. The NIS platform will alert the volunteers to enable them initiate health promotional activities For the community-based volunteers that we are using, we did not also train them on the surveillance, we also train them on health promotional activities. So after the NIST platform reply, we also, the SMS reports are automatically fed into the NIST platform, which aggregates and analyzes the incoming reports in the visual dashboard, which is being accessible by the state governments, the state governments, and the Red Cross. We, on the NIST platform, various supervisors at all level, right from the national NHQ to the state level and also to the local government level, were also included, so that as on the dashboard, they were able to have access to the information that are also passed by the volunteers. After then, the NIST platform will automatically triggers alerts and informing the volunteers and the supervisors that I've mentioned, which include the health authorities, because we don't work alone, we also work with the health authorities, about the increase in the number of the predetermined threshold, because there's a particular number of threshold that's supposed to be. So beyond that, there is a trigger automatically by the NIST platform. So the health authority, based on that, the health authority will be able to take initiative and also respond to those issues. So for the case of Mpox, the cases of unusual fever and rash were reported by the Nigeria Red Cross volunteers. As I said, they don't always do CBS. They also talk about health promotion activities, both in Benue and Borno states. It was also on the record to say that, yes, we had a lot of underreporting in the case of Mpox in some of these states, especially in Borno State. The Nigeria Red Cross volunteer was the first to report on Mpox in Benue State, which also gave us a very loud, in Borno State, which also gave us a good visibility. So after then, what was the action that was taken? We have the documentation of on the NIST platform as a suspected Mpox, and we do all this in collaboration with the government, as I said. And what was the outcome of what happened in both states? There was an investigation that revealed that the symptoms were due to other viral infections, which is not related to Mpox, especially in Borno State. But it was also good that, yes, before our platform was deployed, nobody was reporting on Mpox. So we also, it was a good one for us. So, but in Benue State, the suspected case was later rolled out as Mpox after the series of investigation done by the government, after our volunteers also reported. Next slide. Thank you. So we all have said we also engaged with the Ministry of Health at all levels, starting from the Federal Ministry of Health through National Center for Disease Control and the National Primary Healthcare Development Agency. So there's a strong relationship between the CBS team and the State Ministry of Health Surveillance Unit through regular engagement meetings. Because, for example, when we started the implementation in 2023, we engaged the National Center for Disease Control and the National Primary Healthcare Development Agency in how we can be able to use, because the NIST platform is new, and before the arrival of the NIST platform, other surveillance platform is also being used. So, but we also deployed our own surveillance platform to where the government platform is not being deployed to. So we had a lot of engagements and working relationship with the government at all levels. We also assigned a liaison officer, somebody who is available to coordinate the efforts of the surveillance, the disease surveillance and notification officers, and other surveillance entities. For example, at the national level, I am the one who coordinates at the national level. My replica will also have them at the sub-national level, that is in Benue and also Borno. The same thing we have at the communities and the local government where we are also implementing. In the CBS, we also, there's institutionalization of CBS within the broader surveillance framework by aligning reporting structures with existing state systems. We don't do it independently. We also go along with the structure that the government have. For example, we work through the GSNOs who also have information. As I said before, we deploy this platform to where there are no government existing a platform that was also being used. We also strengthen the established clear rapid communication channels between the CBS network and the State Ministry of Health to ensure swift response following an outbreak. We do as fast as possible to make sure that these cases are also reported. We also have a task force which oversees the activities of the community-based surveillance activities, addressing emerging challenges, because there were a lot of challenges that were also involved. We have a task force who, on monthly basis, sometimes depends on the situation, have meetings to also look at how this will be tackled and rectified immediately. We also involve, as I said before, key ministry stakeholders early in the planning and implementation to facilitate acceptance and ownership. And we all know that community-based surveillance helps to raise voice in our different communities. Next slide, please. So there's nothing you do without challenges. The few challenges we have in the course of these implementations is we have limited access to toll-free reporting lines. We know in Nigeria, we have a lot of network that we have available. So there were issues where the volunteers will send SMS and they need to be the one to pay for it. So for us to get a toll-free line that also suits all the volunteers was a very difficult task at the initial stage. We also have insufficient CBS coverage in conflict-affected, because all our activities are in the conflict-affected local government. So the coverage was not so high, because what we wanted to do was to also complement the efforts of the government and also deploy to a very few communities within the local government where we are implementing. What are our success stories? At the end of last year, we were able to provide a single toll-free reporting line where, irrespective of any network you are using in Nigeria, you should be able to send SMS without you having a credit card on your phone, without you paying for it. You should be able to send SMS while we do the payment at the NHQ level. So all the volunteers can, irrespective of the network they're using, we're able to report using the free toll line numbers that are also recharged by us, but there's no cost attached to them. We also have, as I said before, there's a strong collaboration between the Nigeria Red Cross, our movement partners, and all stakeholders that are also involved in the surveillance cycle. What do we intend to do the next steps? We want to strengthen the CBS framework and funding, because where we have enough funding, we also expected that, yes, we are going to expand the training to involve a lot of community health workers and volunteers, where the issue of insufficient coverage will be enough for us to also go to most of the conflict-affected local governments. Next. Thank you.
Thank you very much, Dr. Adama Abdul, for this wonderful presentation and for also keeping on time. This is really incredible. Thank you very much. So we are going to go through we'll take 5 minutes to try to answer to the questions. Let me just go to the Q&A and select one question. But Dr. Abdul, you can go to the chat, to the Q&A and answer to some questions which are really there. So one question is, what is your experience regarding referral system and the assistance of those referred from the community? So over to you, Dr. Abdul.
Okay, so thank you so much. For the communities where we are implementing, there's what we work around a primary healthcare centers. And in most cases, we also give assistance to some of the cases that were also referred, especially when it is beyond the primary healthcare center. So we also strengthen the referral system by also assist the referral to the next level of care. But for this project that we're also doing and what we have done based on our experience, we don't give cash assistance, but we also make sure that the case that we're also referred to the necessary facility, also make sure that, yes, we'll follow up and make sure that they are referred and also taken care of. Thank you.
Thank you, Dr. Abdul. We still have 1 minute, 2 minutes. So let us take another question. How the state takes charge of community volunteers in Nigeria? Over to you, Dr. Adama.
Okay, thank you so much. In Nigeria, the Nigeria Red Cross is the household name for everyone in Nigeria. We have the number of volunteers nationwide, which apart from the Nigerian Red Cross, other UN partners and other PNSCs are also using. We have our own volunteers and we are responsible. We have ethics and standards and we are in charge of our own volunteers. As I said before, we have volunteers in Nigeria. We have about 36 states plus FCT, and all these volunteers are present in these states. And we also have 774 local governments that are on. So the volunteers are also Nigerians. They are our colleagues that are also living within the communities. So they just belong to us when they register as a member of Nigeria Red Cross. If not, they are also part of the communities, and we register them so that we can also have control over the activities and also look at the ethics of and the standard of what the approach we're supposed to use at the community. So the volunteers are registered, but in some cases where we also work with government, we also have we also inform them to also provide their own volunteers in some cases where they also have a particular skills that the volunteer desire and probably we may not have such. We also we work with the government, also lobby to make sure that yes, we have opportunity of also providing their own volunteers. Thank you.
Thank you very much, Dr. Adam Abdul. Thank you. I will encourage you, please, to go to the Q&A and continue to answer to some questions that the participants are really asking, and they need your feedback on that. Dear participants, I really want to congratulate you on the fact that you are really participating, asking those questions. For the lack of time, you will please go back to the Q&A and you will have the answer to some of your questions there. Now, let me invite Dr. Nadine Muneziro. Dr. Nadine is the National Health Coordinator for the Burundi Red Cross and Public Health Emergency Officer of the IFRC. So, Dr. Nadine, please let me welcome you to present the experience of Burundi. You have 10 minutes starting from now. Thank you very much. Over to you, Dr. Nadine.
Merci beaucoup. Je vais vous présenter la surveillance à base communautaire dans la lutte contre la Mpox au Burundi. La surveillance à base communautaire au Burundi est une stratégie nouvellement mise en œuvre par la force du Burundi. Slide. Slide. Une analyse de la situation a d'abord été effectuée avant de confirmer la pertinence de ce système au Burundi, mais aussi pour évaluer la disponibilité des ressources essentielles et des outils nécessaires à cette mise en œuvre. Slide. Nous avons aussi travaillé sur le choix des localités ou des districts sanitaires cibles de mise en œuvre de la surveillance à base communautaire. Slide sur la carte.
Please, can you move the slide? Thank you. Yes, thank you.
Slide. La carte.
Next slide.
Je disais que nous avons aussi travaillé sur le choix des localités ou des districts sanitaires cibles de mise en œuvre de la surveillance à base communautaire. Et des critères de choix de ces districts sanitaires de surveillance à base communautaire étaient, premièrement, par rapport aux facteurs de risque, qui sont des districts sanitaires frontaliers avec un pays où sévit la Mpox, des cas qui sont supérieurs à 5 nouveaux cas durant les trois dernières semaines, la prévalence du VIH ou la présence d'un camp ou d'un centre de transit des réfugiés ou de rapatriés. Par rapport aussi à la présence d'autres projets de réponse mis en œuvre par la force du Burundi, mais aussi par rapport à la présence d'autres acteurs dans la communauté. Et après l'analyse des différents critères, 4 districts sanitaires ont été choisis. C'est ici le district sanitaire d'Omhanda dans la province de Bubanza, le district sanitaire de Bugarama et le district sanitaire de Rumonge dans la province de Rumonge et le district sanitaire d'Yanzala dans la province de Makamba. Tout ce qui est du chronogramme, Après le choix des districts sanitaires, nous avons fait l'élaboration des modules de formation et de leur traduction en Kirundi. Il y a eu validation des listes des volontaires, agents de santé, TPS et équipes cadres des 4 districts sanitaires à former. Nous avons aussi fait la répartition des volontaires et des agents de santé par colline afin de couvrir toutes les collines des 4 districts sanitaires. Les formations ont été réalisées en cascade, en commençant par la formation des formateurs, puis la formation des secrétaires communaux de la Corse du Burundi et des TPS, qui sont des encadreurs des volontaires et des agents de santé communautaires. Puis, il s'en est suivi la formation de 400 volontaires et agents de santé communautaire à raison de 100 volontaires par district sanitaire. Toutes ces activités ont été réalisées en étroite collaboration avec le ministère de la Santé publique et de lutte contre le sida à travers le Centre des opérations d'urgence et de santé publique, le COSU. Après les formations, les agents de santé communautaire ont été déployés dans la communauté. Ils effectuent la recherche des cas dans la communauté et les signalent au TPS. Quand le TPS valide le cas, il le réfère au centre de santé le plus proche. Le CBS appelle l'équipe d'intervention rapide du district sanitaire pour investigation et pour prélèvement en cas de besoin. Les volontaires et agents de santé suivent aussi des cas contacts, des cas confirmés pour évaluer l'évolution des signes et les réfèrent à temps à la formation sanitaire. Et à tous les niveaux, les informations sont transmises par corporate. Au niveau national, les données sont compilées et partagées aux partenaires dans un site web journalier par le COSU. Slide. Slide. Sur la photo montre slide. Slide. Avancez. Maintenant, nous sommes à la 3e semaine de mise en œuvre de la surveillance dans les 4 districts cibles et une supervision avec le COSP, la Fédération internationale de la Croix-Rouge et la Corse du Burundi a été effectuée afin de s'enquérir de la situation de la mise en œuvre de la surveillance à base communautaire dans les districts cibles. Comme défi, des défis spécifiques au Burundi, il y a l'afflux de réfugiés en provenance de la République démocratique du Congo qui pourrait changer le schéma épidémiologique, surtout par la présence des cas importés ou des conditions de vie dans les camps de transit. Signalons aussi la présence d'épidémies de choléra et les flambées de fièvre hémorragique virale dans les pays voisins. C'est ainsi que le système de surveillance à base communautaire doit être capable de s'ajuster à différentes maladies et au contexte qui est changeant. Ici, je signalerai que c'est pour cela que, lors des formations des agents de santé communautaire, l'identification des signes d'autres maladies épidémiques ou à déclaration obligatoire a été réalisée. Un autre défi très important à signaler a été le gel des fonds de l'USAID qui a retardé la mise en œuvre de la surveillance à base communautaire au Burundi. Comme les fonds appellent, il y a l'engagement de la Croix-Rouge du Burundi à mettre en œuvre la surveillance à base communautaire en tant qu'activité intégrée aux autres activités de riposte que nous réalisons. La surveillance à base communautaire a été mise en œuvre dans un contexte d'une urgence épidémique, mais nous constatons qu'il y a une nécessité de viser la durabilité de cette stratégie. La collaboration entre les agents de santé communautaire et les volontaires de la Corse du Burundi renforce la surveillance à base communautaire. Enfin, Nous saluons aussi le partenariat entre la Croix-Rouge du Burundi et la Fédération, qui a été une clé pour la mise en œuvre de la surveillance à base communautaire à travers son expertise technique. Ainsi, c'est la fin de ma présentation. Merci à tous et je remercie aussi M. Simon pour sa collaboration.
Merci beaucoup, Dr. Nadine Mouneziro. Merci beaucoup pour cette brillante présentation. Chers participants, on a eu quelques petits défis en termes de son, mais je pense que les collègues sont en train de travailler dessus pour que la qualité du son s'améliore. Donc, Dr. Nadine, on va prendre, il y a une question dans la partie questions-réponses que je vais lire pour vous. Sachant qu'après, vous pouvez continuer à répondre aux questions dans la section de questions-réponses. La question est celle-ci. Au regard du haut taux de transmission, ne serait-il pas pertinent d'avoir une composante élargie à la population au travers des centres d'appel aussi? Ça, c'est la question. L'autre question que j'aimerais que vous puissiez répondre, c'est comment le Burundi s'assure-t-il que le système d'alerte précoce est efficace et accessible aux populations locales? Docteur Nadine, à vous pour nous apporter des éléments de réponse à ces questions. Merci beaucoup.
Vous pouvez répéter la première question?
Alors, la première question, c'est au regard du haut taux de transmission, ne serait-il pas pertinent d'avoir une composante élargie à la population au travers des centres d'appel aussi? Merci.
Merci pour la question. Pour la première question, pour avoir une composante élargie, la première chose qu'on a fait, c'est d'associer les volontaires à ce système de surveillance à base communautaire en même temps que les volontaires. Nous sommes confiants qu'ensemble, les agents de santé communautaire et les volontaires vont travailler beaucoup plus avec synergie qu'avant, où c'était seulement les agents de santé communautaire qui travaillaient seuls, ou bien que c'était les équipes d'intervention rapide du ministère de la Santé publique. Aussi, avec le système de reportage avec Tobo, les données sont rapidement transmises et on espère que les messages vont arriver à temps et directement au lieu de faire des rapports papier qui mettaient du temps à arriver à destination.
Merci, docteur Nadine. Cette partie de la question demandait aussi, est-ce qu'on utilise aussi les centres d'appel pour élargir l'accès aux populations? C'était aussi ça une partie de cette question. Merci.
Ah oui, oui, à la Croix du Burundi, nous avons une ligne verte de 109 qui est connue dans tout le monde et les opérateurs sont là 24 heures sur 24 et 7 jours sur 7 et la population appelle pour poser des questions et ils ont des réponses à temps réel. Récemment aussi, il y a une ligne verte du ministère de la Santé publique au 117 qui est aussi opérationnelle depuis récemment. Et donc, la communauté peut passer aux deux lignes pour poser les questions ou pour s'inquiéter de la situation et ils reçoivent des réponses directement.
Merci beaucoup, docteur Nadine. Merci beaucoup. Je vous sollicite pour que vous répondiez aux questions dans le chat. Il y a quelques questions encore pour que vous puissiez aller dans la section des questions-réponses, s'il vous plaît, et continuer de répondre. Aussi, j'encourage les participants à continuer de poser les questions. Il y a plusieurs experts ici parmi les organisateurs. Ces experts-là vont continuer de vous apporter des réponses adéquates. Merci beaucoup. Merci beaucoup, Dr. Nadine. Please, we are going to move to the Slido interaction with the participants. I will give the floor to my colleague to take us through these pool questions and enhance the participation of people who are listening to us. So you have the questions here. Maybe I will give you the floor to take us through this. Over to you. So maybe let me read the question. I hope the translation is active. What comes to your mind when you hear of community-based surveillance? Please use your Slido to answer to this question. Thank you. We give you 2 minutes to answer to the question. Over. Someone is asking me to repeat. The question is on your screen. I hope you can see the screen. The question is, what comes to your mind when you hear of community-based surveillance? Please enter your answer here for that first question. You can read it on your screen, please. The second question is, what have been the challenges in implementing community surveillance? Please, you can write the answer on your screen. It seems like some people cannot see the question in their screen. Maybe I can copy and paste it in the chat to make it easy to you. There you go with the first question. And the second question, the two questions, I've posted the two questions in the chat for those who are not able to see the questions in their screen. Please continue to answer. We will close this in 1 minute. Thank you. Thank you very much. Please continue to answer. And now we are going to close the poll and ask to my colleague to display the result. Thank you, Aditi. Yes, thank you. It seems like you have answered to the first question, and it seems like all the answers are correct because we have the full result here. And for the challenges, we have at least 90% of people that have answered, and I can see that the answer are continue. Some of the answer that we have, I can read some answer here in the chat. People say that the community-based surveillance is the process of empowering communities to detect, respond, and monitor disease outbreak within their communities. Some challenges range from community of continuity of the activities. When partners leave the country or the project, the national government does not put money to continue community-based surveillance. And we have also the issue of reporting health-related issue. We have a challenge of the lack of cooperation from the members of the community. I think that please continue to answer, and I would like really to thank you very much for your participation to answer to these two questions that were posted for you. And what I can say is that from your question, we can conclude that you really understand what is community-based surveillance and the challenges. It means that you have been following very well our presenters during this webinar. So I think, Aditi, we can close here the poll questions and the answers, and we move to our last presentation, which will be done by Dr. Aimé Mbonda. Dr. Aimé is the Health and Care Coordinator for IFRC Central African Cluster. So Dr. Aimé, you have the floor. And for this, I think that you have 30 minutes to make your presentation. Thank you very much for taking the floor, Dr. Aimé Mbonda. Over to you.
Okay, thank you, colleagues, and good afternoon to everyone. It is real pleasure for me to be here today to present on community-based surveillance in public health emergency. So as the moderator says, I'm Dr. Aimé, and I'm honored to share insight on how community-based surveillance strengthens diseases surveillance and response systems, particularly in low-resource setting. Before we begin, I would like to highlight that this presentation will provide practical insights into community-based surveillance and how it is integrated with national health structures. So let's start with an overview of what we will cover today. In this session, we will go through the fundamentals of community-based surveillance and its comparison with other surveillance methods. We will go through how communities play a critical role in early detection and response to diseases like Mpox, Marburg, and Ebola. We will share the best practices of setting up community-based surveillance and linking it to national health system. We will also share how the data transmission process in CBS and why real-time reporting is crucial. And finally, we will end by the importance of coordination and collaboration in making CBS effective and sustainable. Let's begin by looking how different surveillance systems functions. Next slide, please. Okay, public health surveillance relies generally on three keys approach. The first one is indicator-based surveillance, which gathers structures reports from health facilities and help track diseases trends over time. Second system is event-based surveillance, which captures unstructured data such as community rumors and major reports for rapid investigation. And finally, our community-based surveillance, CBS, which actively involves community members in detecting, reporting, and responding to health threats at the grassroots level. CBS is particularly important because it serves as the first line of defense against outbreaks like Mpox, Ebola, or Marburg in areas with limited healthcare access. It combines both passive and active surveillance, improving early warning and response capabilities. Now that we understand CBS, let's talk about how community case definition make diseases detection simpler and more effective. Next slide, please. To ensure community-based surveillance is effective, community members need simplified case definition to identify and report potential health threats. This definition focuses on few priority diseases that have a high risk of outbreak. They are co-developed with ministries of health and key stakeholders based on past epidemics and current threats. They ensure early warning and rapid action, especially in settings where people may have not access to professional health care. For instance, during the Mpox outbreak, a community case definition may include unusual skin rashes, fever, and swollen lymph nodes, allowing early detection and intervention. For hemorrhagic fever diseases, we can have also severe fever, bleeding from the nose, eyes, mouth, skins, gums, or blood in stools, vomit, or urine, not due to an accident, or a person died after an unexplained severe illness with fever and bleeding. Next slide, please. So I4C and WHO have developed an interim guidance on strengthening community detection and response during Mpox outbreaks. We will focus on this because this is really a key document and guidance who provides a community-centered approach to early detection and rapid response, ensuring that the Mpox outbreaks are identified and managed effectively. At its core, the approach emphasizes engaging communities to identify at-risk population and transmission partners. By strengthening health detection, education, and risk communication, we empower individuals to recognize symptoms and report cases early. The framework relies on community-based surveillance, including self-reporting, local health screening, and verification by medical personnel. These efforts are then integrated into early warning and national surveillance system to facilitate timely intervention. To sustain this approach, the guideline highlights three key enablers. First one is strong community partnerships with public health facilities, with volunteers, with civil society organizations. The second enablers is linking communities with national health system for a coordinated response. And finally, building the capacity of community health workers and volunteers to improve long-term preparedness of community. Next slide, please. As you may know, certain populations are at higher risk of Mpox infection, including people living near wildlife habitats, hunters and bushmeat vendors, healthcare workers and laboratory staff handling samples, individuals with low immunity, including pregnant women and children, and communities with low vaccination rates. Now that we understand the risk, let's explore the best practice for setting up an effective community-based surveillance system. Next slide, please. Setting up a community-based surveillance system requires a structured and strategic approach. Here are some best practices, but you can also go among the detailed SOPs to guide the process. The first point is to develop a standard operation procedures, which will define the role, the responsibilities, and the workflow for community-based surveillance implementation. The second is to ensure that consistent data collection and reporting tools across different communities are available. Finally, we need to engage communities and train them. Train the volunteers and also the community health workers is crucial for sustainability. They must be equipped with knowledge on community case definition, reporting mechanisms, and basics response action. We have to take in consideration that every community-based surveillance system that we are implementing or integrating is integrated with the national surveillance system. It should not function in isolation, and it must be linked with the national health structures for effective response. This requires a strong coordination between local, regional, and national health authorities. Finally, we must take in consideration the use of technology for data collection. Mobile tools like NIS, I think we had this with Nigeria and other colleagues, enables real-time data reporting, improving efficiency. But also take in consideration that SMS-based reporting allow quick alerts, even in areas with poor internet access. Next slide, please. So community-based surveillance system and success depends on strong partnerships. Community members should be actively involved in planning and implementation. Collaboration with all stakeholders can improve the case detection and contact tracing, and local organizations, religious groups, and national NGOs should enhance trust and community reach. Also, government authorities should ensure community-based surveillance integration into the national health structure. And finally, informal healthcare providers and community volunteers are really key in cases detection and health education. Take in consideration that technology plays a vital role instead of digital tools like NIS or COBO or other tools like AWAS with other organizations. Next slide, please. CBS relies on multiple data transmission methods, including mobile data collection tools, where volunteers can send alerts via SMS or mobile app, paper-based reporting, which is still used in areas with limited digital access, digital platforms like NIS or other platforms which centralize and share data with response teams. And we have to consider that the goal is to ensure a timely and reliable data flow from communities to health authorities. However, take in consideration that data reporting is only as good as the verification process. So now let's discuss how we handle this type of reports. Next slide, please. Okay. Community-based data collection occurs at multiple points to ensure timely and accurate reporting. I think this is what is very good with this system. First, during community engagement, when you have volunteers or community health workers, which are doing health information, health education, they can also immediately identify suspect cases and report to their supervisors. When a suspected case is identified, sorry, there's someone speaking. Okay. When a suspected case is identified, immediate reporting through mobile or paper systems are done. First is going to the supervisor, which is either a Red Cross, since we are talking about Red Cross here. It's either a Red Cross supervisors, which has received an intense training to be able to check if the community base or the community case definition is correct or not. Based on this, when they identify this, they can first either escalate to the health authorities for investigation, or they can immediately do a feedback to the volunteers to say the community case definition you sent the report is not matching. When it is a true report and it is escalated to health authorities will immediately investigate and incorporate into the national surveillance system reporting. This may occur and push for a local or national response depending on the fact that it's a true or false report and if it is a confirmed or not confirmed cases. Slide, please. To maximize its impact, CBS must be fully integrated into national health system. This ensures a smoother coordination between CBS and formal health services, a better data sharing, improving outbreak detection and response, and a long-term sustainability, making CBS a permanent part of disease surveillance. Take in consideration that we have key strategy for integration, and it includes assigning focal points in ministries of health to oversee community-based surveillance, but also in other ministries like the animal ministries to take in consideration the One Health approach. We also have to consider that CBS data is fed into the National Health Information System, such as DHS2. We have also to take in consideration that we must align the CBS efforts with broader public health emergency plan. By making CBS a formal part of national surveillance, we strengthen the overall disease preparedness and response. Slide, please. So before we conclude, I would like to acknowledge the contribution of our colleagues, Dr. Elizabeth, Dr. Mohamed, which has really supported us on this. Slide, please. And in conclusion, I would like to say that community-based surveillance is a powerful tool for detecting and responding to public health threats. It strengthens early warning system, it enhances community engagement and ownership, and it integrates with national surveillance to ensure sustainable impact. Thank you for your attention. I look forward to any questions or discussion. Thank you.
Thank you very much, Dr. Aimé. Thank you for this brilliant presentation. Thank to you and to all the presenters that they have done their best to share with us this important insight. Thank you. So participants, we will take 5 minutes to answer to your questions. Let me go to the Q&A. If there are some questions there for Dr. Aimé and also for the rest of the presenters. So I don't have, yes, Dr. Aimé, I have one question in the Q&A for
Dr.
you.
Question à vous poser.
Sorry? Ah, thank you. So I have one question in the Q&A for you, Dr. Aimé. Someone said, the presenter said among the risk factors for Mpox is low immunization. What immunizations are being referred to? This is one of the questions for you, Dr. Aimé Mbonda. And yeah, if you can answer to that, maybe I will take another question and we continue to answer in the Q&A. Thank you.
Okay, thank you for the question. Definitely immunization refers to the immunity of the community's members and at the individual level. So this is why we are promoting vaccine take-up. Like you can see in DRC and in other countries, we have been promoting the vaccine take-up. So globally, it's around immunity, and this is not only about vaccine, but it's also about immunity deficiencies, like some conditions who can reduce your immunity. like being a pregnant woman or children or having other diseases, chronic diseases can reduce your immunity and therefore makes you more at risk of contracting the diseases like Mpox or other diseases. Over.
Thank you, Dr. Aimé. I have another question that I would like you maybe to answer. This question is in French. The question said, comment garantir que les données collectées par la surveillance à base communautaire sont fiables et utilisées de manière transparente sans stigmatiser certaines communautés, surtout dans les zones déjà affectées par la peur et la méfiance envers les autorités sanitaires. Over to you, Dr. Aimé Mbonda.
Oh, thank you. That's a really good question, and I really appreciate it. I will expand on this. So normally, the first point is to assure the data privacy. So this data, they are not shared everywhere. They are in the national health system, and the country is handling it. That's the first point. The second point is concerning stigmatization. Definitely keeping this data as private as much as possible is helping to reduce the stigmatization, but also reinforcing on health education, health promotion with the community volunteers is really important. This is why we are first training community-based volunteers or community health workers, and we have to take in consideration that these community health workers or volunteers are identified by the people in community. So these people are people that the community trusts, and therefore these people are not going to share some specific information to all the communities, and this will also reduce the stigmatization. And like I was saying, health promotion is the key, explaining that you can get cure of the disease and you will no more be infectious or giving the disease to other people, really. Finally, continue health promotion, support, engage with the specific leaders like the religious leaders to reduce also the stigmatization, and also put in place a feedback mechanisms in communities to identify this stigmatization and reduce it through different channels. We have been able to put channels like suggestion box or call centers, so you can take all of this in consideration. Over. Thank you.
Thank you very much, Dr. Aimé. Thank you for all the questions. Please, colleagues, you can continue to respond to the questions of the participants in the Q&A section. I'm just checking if there is one question more that we can take. Yes, Dr. Aimé, I think that you will like this question. The question is how to ensure bottom-up effective community-based detection of cases. Dr. Aimé, how to ensure this bottom-up effective community-based detection of cases. Over to you.
Oh, thank you for this brilliant question. I really appreciate the question that I'm receiving. Yeah, definitely. We need to train the volunteers to give them the good community case definition. And also we need to ensure that they have been receiving feedback. Like, let me take the example of Mpox. Really, sometimes you will have other diseases like varicella or other diseases who are measles. People, sometimes people are confused. Is it measles? Is it Mpox? Or is it other diseases? So usually when a community volunteer who has received a good training and briefing is sometimes reporting false alerts, we usually need to train him, to give him the good feedback, and also to explain to the community that all the cases may not be confirmed cases, but we really need to give them the good information. Now, like I was mentioning during the presentation, these need to be integrated and at all the level, local level, regional level, national level. This will help the country system to understand what is happening in the ground. As you may have noticed, we are having now several diseases where we don't understand what is it. If we don't have a good bottom-up community-based surveillance system, this will not be helpful, and this will encourage stigmatization, rumors, infodemics, this type of things. So definitely, I think we need to ensure that there's a good integration. We need to give good feedback to our community volunteers, community health workers, and we need to take in consideration they are the one in front, and we need to encourage them, congratulate them, and give them the support they need. Over.
Dr. Eme. The questions are, there are some questions again in the Q&A for all the presenters. Please, I encourage you to continue to respond, because the participants are really, they are really smart, and they have very good ideas and questions that they need really to have your insight and your experience on that. So, dear participants, dear colleagues, we are quite at the end of our webinar. First of all, I would like really to apologize for some IT issues that some of you faced during this webinar. We will try to ensure that next time we really do it better. We have the IT question solved, but as you know, we are not always at the top of mastering all the IT issues. So I apologize in my name and in the name of all the presenters and the organizers. Community-based surveillance, yes, we have talked about it in Mpox, Marburg variant disease, and Ebola variant disease, as our presenters are really brilliantly presented. But I would like also to insist that to be effective during outbreak response, community-based surveillance have to be put in place during preparedness and readiness. It is a process. It is an unstoppable process. We cannot just wait for the outbreak to put in place the community-based surveillance. We have to start the community-based surveillance. I don't know when, years before, and the community-based surveillance will continue during the outbreak and after the outbreak. This is why if we continue doing community-based surveillance, we can ensure that when we have an outbreak, we will be able to really engage our community health workers, all the stakeholders, to really cross-cuttingly work to implement community-based surveillance in order to stop the chain of transmission and continue the engagement of our communities, because outbreak starts at the community, and at the community is where the outbreak is we have to end. So I would like to thank all the organizers, the presenters, and all the participants from the 5 continents. We have people from India that, despite it is late there, they're still in this call. I would like to thank you very much. People from the American continent that woke up very early, they did their job, and they came to attend this webinar. People from Europe and for African continent, of course. Thank you very much. Thank you very much for your high participation. This webinar is the first of a series. We will be delighted to continue to share knowledge with you, and also to collect your valuable insight and your valuable contribution. We will call you again for the next webinars, and on that, I will really like to thank you very much, and make sure that all the partners will continue to work with the national government to enhance community-based surveillance for the resilience of communities and of health system. Thank you very much, and see you next time. Thank you.